He was past president of the American College of Cardiology, California, and served on the medical advisory board at the Los Angeles Zoo, where he served as the cardiologist for the great apes. Dr. Wright is a renowned lecturer and co-authored the first US guidelines on the management of patients with heart failure, a recipient of the Specialist of the Year Award from the American College of Cardiology, California, and is continued to be listed in peer surveys as one of the top cardiologists in the state. And who could disagree more? Rich, grateful for you to come in.
The slide advancer is just from the iPad. Oh, here it is. Okay, thank you. Well, thanks, Mo. It's always a delight coming here. And I just want to applaud you and Sabine and the others for continuing to throw a terrific meeting every year. I'm going to talk about heart failure, and he asked me to give you pearls and pitfalls and fake news, a common wording that a few years ago I never would include in the title of a talk. But nowadays it seems apropos. Obviously, heart failure is a big thing. I mean, you could have a 4-day conference on heart failure. So I'm going to be selective, and we're going to talk about a few things. I'm going to talk about, you heard about the obesity paradox. I'm going to be talking about salt. I'm going to be talking about amyloidosis, and the reason I'm going to talk about that is the biggest single change in heart failure that we've had in years is in this niche of amyloidosis, but hopefully I'll educate you about why it's not such a small niche. And then I will talk about my main thing that I do every day, which is to take care of heart failure patients with focus on those with systolic heart failure. These are my disclosures. Many of these companies make products in the heart failure arena, and I advise them about that. I don't have any equity with any of these. So first, let's define what we're talking about with heart failure. It's important to understand that heart failure is a syndrome. What that means is there's not a specific entity or disease that leads to heart failure. It's a bit of a grab bag term, and that has led to tons of confusion. So I could throw any of you into heart failure if I just put an IV in and then put in 3 liters of normal saline in 10 minutes. You could have a totally normal heart and kidneys and lungs and everything's normal, but if you're grossly, acutely volume overload, you, quote, go into heart failure, right? And that leads to confusion as to what is heart failure and what is the treatment of heart failure. So we're not going to talk about somebody who mistakenly was put into heart failure iatrogenically. We're going to talk about a syndrome, not a disease, in which the heart fails to do its job, right? So what is the heart's job? The heart's a pump, and a pump is required to deliver a certain volume of something, in this case blood, and at a certain pressure. And any of you who have pumps, and whether it's a swimming pool or an aquarium or a sump or anything, knows that weak pumps can't generate very much pressure, and maybe the volume that the pump can pump per minute. And these are very applicable, actually, to the heart. And it's important that the heart be able to do that without flooding the lungs or the body. So the most common symptoms that people have with heart failure are related to flooding. No one comes in and says, my cardiac output is low. That just never happens. So what they're going to say is, I'm short of breath, or maybe I have peripheral edema, and that's this constellation of things that leads to excess fluid, basically, that can flood the lungs and make the work of breathing harder, or flood the body and lead to retention of fluid, typically in the ankles and feet. And this is a very common clinical entity. In fact, everybody in this room basically has a 20% chance of developing heart failure in their lifetime. So this puts it in the same, it's not as common as, say, high blood pressure, but it's around as common as atrial fibrillation. And this is partly because heart failure does reflect age, as depicted here both for men and women, and these are people followed for 26 years who started without heart failure, and then they ended up 20% of the time with heart failure. If you look at these closely, you'll see that men tend to develop heart failure sooner in life than do women. So if you take, say, a 60 or 70-year-old, most of the 60 or 70-year-olds with heart failure are men, and that's reflective of the fact that coronary disease occurs earlier in men, and hence heart attacks, one of the causes of heart failure, will occur more commonly earlier in men. But women catch up, And by the end of lives, there is no difference between men and women, and that's partly because women live longer and hence have more time to develop the consequences of aging. So if you look at systolic heart failure, impaired heart contraction, that's more common in men. So-called diastolic or preserved ejection fraction heart failure, more common in women because they're older. Okay, now we'll make that distinction when we talk about medications because the medications are quite different for those two entities. Many, many things, as you can imagine in a syndrome where the heart is struggling, there are many things that can lead to that. And these are the common ones that are listed here. And some of these it's actually difficult to distinguish. So if 70% of old people develop hypertension and 20% of people who are old develop heart failure, it's hard to distinguish whether it's the aging that leads to both of these or whether it's actually the hypertension. But these are the common things that are listed. And there is some validity to the fact, for example, that if you treat high blood pressure appropriately, whether it's with lifestyle changes, weight loss, you heard about exercise, all of which improve blood pressure, but actually if you treat with medications, you can prevent heart failure. And the biggest thing, if you take men or women over the age of, say, 70 and treat high blood pressure, it's not preventing heart attacks that drives the equation of what does medicine do for high blood pressure. It's actually preventing heart failure. So hypertension is important to treat. And of course, if you can avoid myocardial infarctions, you're going to have fewer heart attacks. Down the list, there's some things that have risen to prominence, though, partly because science has advanced. So partway down the list is genetics. Now, we used to think that genetics in heart failure weren't that important. But now that we can do gene testing for $249 or less, it's amazing the conditions we used to ascribe to something else. And a perfect example is alcoholic cardiomyopathy. You know, why is it that there are bums living under a bridge drinking every day who never develop a heart problem and others do? Turns out the ones who do are genetically predisposed. And so the alcohol is the final trigger in those people. And the same thing is true of peripartum cardiomyopathy, this unusual condition in which women will develop at or around the time of delivery heart failure. It turns out they have genetic abnormalities over 2/3 of the time that lead them to have this. So sometimes the stage is set by bad proteins in your heart, and then something like alcohol or pregnancy or something will trigger it. Now, this may emerge in the near term to help us, because if we can identify what's wrong with your gene, maybe we can then, cure that or treat that. We haven't yet gotten to that point. I will show you glimmers of that. The oncologists are way ahead of the cardiologists in terms of this molecular personal health care. But I'll predict that cardiology will get there in the next 5 years. And then there are other things, exposure to toxic agents next to last. That has risen to prominence in the heart failure field because of chemotherapy and immunotherapy and all these new therapies, particularly in breast cancer patients. And there's a legitimate reason for that. It turns out that the breast and the heart actually have similar proteins expressed and antigens expressed. And when you attack breast cancer, about a quarter of women with breast cancer treated with modern therapies will have heart dysfunction manifest during their treatment. Now, the good news is some of those, once the treatment is completed, the heart comes back, but others it does not. And heart failure clinics are full of women who unfortunately have the residua of successful breast cancer treatments. Now, these causes can be broken down into two different treatment groups, and the only importance of this is that the medicines that we're going to talk about in a minute, and some of the diagnostic tests as well, differ totally. So if someone comes in to you and says, I can't breathe and I have edema, and you do an exam and it's not because they have horrible chronic lung disease or whatever, and you've made the clinical diagnosis of heart failure, perhaps helped by blood tests and other things, about half of the people with that complaint will have reduced heart performance, reduced squeeze of the heart or systolic performance, usually measured on an echo, but it can be measured other ways as well. And those are called the patients with reduced ejection fraction heart failure. There are, however, people that have impaired filling of the heart. This is the other half of the group. We'll be focusing on them in a minute because we're going to talk, as I said, extensively about this amyloid heart condition. But these are people whose hearts don't relax appropriately. And the analogy I use when I tell patients that they have this condition is, at least in LA, if you go to Gold's Gym and you see these guys who are abusing growth hormone and abusing steroids, and they walk in, they look like the gorillas I took care of at the zoo, honestly. But in a sense, they're muscle-bound, and your heart can become muscle-bound also, right? So if the heart is so muscle-bound that it cannot accept blood, then it's going to have a difficult time propelling blood forward because it doesn't have any blood in the container because it hasn't relaxed. So that is preserved ejection fraction heart failure, most commonly seen in the elderly, and it's typically attributed to hypertension and diabetes and scarring and other things, but there are many causes of impaired relaxation of the heart. So it's about 50-50. And when we talk about drugs for heart failure, so there are booths out here about heart failure medicines and the medicines that I dispense every day, most of those are actually in the systolic heart failure group, not the so-called diastolic heart failure group. But no matter what's wrong with your heart, whether it doesn't squeeze or it doesn't relax, the symptoms are the same. You cannot distinguish at the bedside whether somebody has a poor pump because it's not pumping or a poor pump because it's not accepting blood. The most common symptom is related to flooding of the lungs, and that can be anything wrong with the heart. Even if your muscle's perfectly fine, if your valves are bad, for example, your lungs can get flooded and you will have the symptom of breathlessness. And that's also true of water retention, fluid overload. Not so much because the heart's struggling, but once the heart is not doing its job, then a sequence of events occurs where the kidneys are told to hold on to extra water, and then you basically are like the chickens they sell where they give more water so that the weight is greater so that you spend more money in a chicken that's just water, that's what it is. And that's due to mostly the kidneys listening to instructions. There's nothing wrong with the kidney, it's just been misinstructed. And indeed, when we talk about diuretics in a minute, what diuretics do basically is just countermand the instructions to the kidney so that the kidney can rise to the occasion and do its job. So here's a depiction of the 50% of people that have impaired heart function, right, systolic function. So the heart's typically enlarged, and by enlargement, I don't mean thickening of the muscle, I mean the heart is physically larger. The inside cavity dimensions are larger, and there's usually a reduced squeeze of the heart measured most commonly as ejection fraction, and this is what most people think of when they think of heart failure. And then there's this group, these are the Gold's Gym muscle-bound people, in which the chamber is typically small and hence doesn't have a lot of blood contained in it. So even if you have a good squeeze, let's say you have an ejection fraction of 65%, if it's 65% of no volume, then you're going to have no cardiac output, and the kidneys will sense there's a problem and start holding on to water, and this leads to the same heart failure syndrome. Now, with that as background, I want to talk about one thing that's been quite controversial, and that is salt. Right? There are lots of papers on salt. I am absolutely sure that the guidelines that you have in your hospital or your clinic tell people to avoid salt for lots of reasons, and let's explore whether that's actually legitimate. Is that a truth, or is that a fiction? So here's an important observational study. This wasn't a randomized analysis, but they took 500 patients basically with heart failure, and left to right is the prognosis, just looking at the combined endpoint of death or being admitted to the hospital with heart failure. And here are two groups, okay? One of the groups is eating less salt than the other. The number here was 2,500 milligrams of sodium per day. Now, if you look at those two groups, say, okay, left to right, the event rate on the vertical axis, the red group is clearly doing a lot worse than the blue group. And so the question is, which group had the lower salt intake? And according to what you hand to your patients with heart failure to say, avoid salt and do this, you're hoping that the sodium-restricted group would be the blue group because they're doing better than the red group. But in fact, that proved not to be the case. In this analysis, the people who were eating more salt did better, highly statistically significantly better. And if you look at the difference between 42% and 26% at the end of 3 years, that is huge. That difference is greater than most medicines we give. It's greater than putting in defibrillators. It's better than doing stents or bypass. I mean, this is like, are you kidding me kind of data. And the curves diverge within 1 month. So these types of analyses brought into question our dogma that low sodium is important, low sodium intake is important for people who have heart failure. And in fact, in that same study, here are the three different, in that article, I've shown you the one on the left, the combined endpoint. Most of this was driven by heart failure hospitalization on the right. So if you want to keep people out of the hospital, and I guarantee you that your hospital wants to keep people, at least readmissions, out of the hospital because they get penalized, and 2/3 of all the hospitals in the US got penalized for having too many patients readmitted after a diagnosis of heart failure. So one way to do it, at least if you believe this particular analysis, is not to tell them to avoid salt. Now that seems counterintuitive, right? But as you heard from Carl, sometimes things that seem counterintuitive actually turn out to be right. I mean, our intuition isn't science, it's just a sort of a feeling. So let's see if there's other data to support that salt restriction is not helping patients with heart failure. So here's an analysis in that particular same study that I just showed you. And they asked the question, well, maybe it matters whether you're older, younger, male or female, or have reduced ejection fraction, or you're on an ACE inhibitor, not on a, and all these things, none of them made a difference. The group that ate more salt did better, okay, across the board. Well, let's see if there's a meta-analysis. Turns out, in this meta-analysis that was just recently published, there were 2,679 studies purporting to try to address, is salt intake or salt reduction important in heart failure? 2,679 studies, okay? Of those 2,679, 27 met criteria for being good studies. Okay, well, that tells you there's a problem there. And of the 27, only 9 actually had modern statistics and things. And of those 9, 0 met current criteria, 0. So the guidelines that we promulgated, and Mo told you I spent 2 years on a guidelines writing committee for heart failure, and we argued incessantly about this because there was no data. If there are no data, then how do you make a statement about whether you should put salt in or not? Turns out of the studies, those 0 studies that met it, but there were some that purportedly were well designed. Here they are. These are all the studies in the world in which there was actually randomization and normal things that we do. And the largest of them had 97 patients, okay? Most of the trials that I'm going to talk about in a minute for heart failure management have 4,000, 8,000, 18,000 patients, not 97 patients. We have all these guidelines and booklets and stuff based on studies that are completely ridiculous, okay? There are no data to support that salt restriction helps patients, and hence, fact and pearl number 1, there's no compelling evidence that salt restriction helps patients with heart failure. None, even though everybody here tells our patients to do that. Now, in fact, it's possible that extra salt may help patients. Now, how's that possible? So here's the logic. Now, it is true, and Chris Mendy, when he talks, I don't know if he's going to address, in societies that have very low sodium intakes, right? So if you look around the world, the highest salt intake in a general region is in northern China, where they eat 6,100 milligrams of sodium. The lowest is the Yanomamo Indians in Brazil, and they don't eat 2,000 or 1,000, they eat 38 milligrams of sodium, right? So if you look at that group that is ultra low sodium, because there is no salt in the Amazon, it turns out they have low blood pressures. So there is no quarrel that, from a societal perspective, salt intake correlates with blood pressure, and hence over the long haul, maybe they have less heart failure because they have less hypertension, and that's a legitimate argument. But once someone has heart failure, everything is different because the neurohormonal milieu is different for a heart failure patient compared to a normal patient. So if you look at the bottom half of this diagram, here's the concept. If you give salt to a patient, in red is the blood supply to the kidney here. If you give salt, the kidney will sense that it needs to get rid of salt because now more salt is being presented to the kidney. The kidney says, hey, this is inappropriate. I need to do my job and eliminate this salt in the urine. Well, when the kidney makes urine and gets rid of salt, there's an obligate water loss with that. And it turns out, therefore, if you give salt, you may actually promote the excretion of extra liquid. So there were some bold investigators who said, okay, let's take people who are admitted to the hospital with decompensated heart failure and are volume overloaded, and let's give them salt. You know, that's not something you probably do at your hospital. In fact, when I started doing this in my hospital, I got calls from the nurses saying, what the heck are you doing? You know, are you kidding me? But it turns out here's what happens, and this is a little busy, but I'll tell you what happens. You have a patient come in with decompensated heart failure. They're known to have a heart failure, they're volume overloaded, they're 10 pounds overweight or 20, they have edema, the typical thing we see. Now, you can randomly assign these people to the normal treatment, which should be, let's give IV furosemide and the normal stuff, or you can randomly assign them to giving them salt. In this case, they were given intravenous salt. They were given hypertonic saline, something most of you only use if someone is hyponatremic, right? So low sodium, sometimes we give hypertonic saline. Hypertonic saline is 3% sodium chloride. Your normal is about 0.9% for your blood. So we're giving 4 times saltier fluid than is present in your bloodstream. And once you give that, if you do that, and you also give the furosemide, so the study is furosemide alone or furosemide plus extra salt, what happens? Okay. So if you look in the light blue group, with or without the hypertonic saline, and these numbers are stunning. So what was the benefit in terms of death? Death, right? You heard from Dr. Levy that death is easy to measure. That's why it's a preferred endpoint by some people. And in fact, I've been at study where we're designing studies. They go, we can't do the study because not enough people are going to die. And can't measure it if they don't have it. Well, it turns out there was a 54% reduction in death for the people given salt. There was a 47% reduction in hospital readmissions for heart failure in the next 30 days. Now, somebody going to the home, doing a nurse practitioner at the home and seeing a patient within the week and sending them home with scales and all this stuff, none of those things work. The best medicine lowers readmission rates by 38%. If you gave salt, you lower it by 47%. I mean, this is like, in fact, this was so stunning when this article was first, they couldn't get it published. They sent it to journal after journal and nobody would accept it, saying, this can't be true, can't be true, right? Their hospital stay was also lowered by 2 days. Now, if you told a hospital administrator, I'm going to get the people out of the hospital 2 days sooner, and they're going to live longer, and they're not going to be readmitted to the hospital, to me that would be a slam dunk. But it wasn't, because it was against dogma, the dogma that sodium must be avoided. The other thing that's not listed here is many of you have had the experience, somebody comes in the hospital, they get a lot of diuretics, and then their kidney function seems to get worse, right? The creatinine goes up, and people call this the cardiorenal syndrome, and there are all these. If you give salt, you totally avoid that. Creatinine stays the same. Urine output doubles. They do better, right? And in fact, that wasn't a unique study. These are the numbers that I just wanted to point out about mortality and readmission, both improving when you give salt. There are now 4 studies that show the same thing. Now, this has changed. You heard that I oversee heart failure for 50 hospitals in the Providence chain up and down the West Coast, and we had a conference call yesterday about changing our guidelines, because with this type of information available, why would we still hand a brochure to somebody and say, we want you to go home on a low-salt diet, sir? So as of Friday, we eliminated that from all 50 hospitals in our system. We no longer tell people to avoid sodium. We're trying to, in all 50 hospitals, put into place, give salt during decompensated heart failure. And I'm absolutely convinced we're going to have 50 hospitals rebelling against that advice, but it is what the data shows. So fact and pearl number 2, giving salt may help patients with heart failure. That's just so counterintuitive. Now, the important caveat here is you may need to give diuretics with the salt for this to work. And that's what the information of the decompensated heart failure in the hospital is. They gave it with intravenous furosemide. But the kidney can't do its job if it's not being given salt. So when you give salt, the kidney wakes up and makes more urine. Now I want to switch gears to I told you there was a revolution in the last year or two in one unique area of heart failure, and that's called amyloidosis. If you look in most textbooks, it'll say amyloidosis is a rare disease and blah, blah, blah. I'm here to tell you it is not a rare disease. It was a rare disease because we couldn't test for it. And we thought people that had other diseases, and we attributed the problem to these other diseases, but in fact, some of these people had amyloidosis. What is amyloidosis? And now we have treatments for amyloidosis, and it's much more common than we thought, so let's go into this. This is what an echo might look like in an amyloid patient. So we have the heart. Let's see, does this thing work? Okay, there it is somewhere. Well, so the heart is thick here, the atrium is enlarged, and there's a little pericardial effusion. These are typical findings for amyloidosis presenting to an echo department, probably because the patient had breathlessness and heart failure, et cetera. This is what somebody, obviously they didn't survive because the heart is in cross-section here at a pathology specimen. This is an amyloid heart, and you can understand why the person is not feeling well, because that chamber in black there on the right is the entire volume of the left ventricle. And even if you had an ejection fraction of 100%, 100% of 10 milliliters is not sufficient to provide adequate blood flow to the body. So when these people die, they die indeed of cardiogenic shock related to poor blood supply being provided to the body because the chamber usually in these people is just much too small. Now, what is amyloidosis? So amyloid has risen to prominence not just because of cardiology and heart failure, but because a form of amyloid is thought to be the contributor or cause of Alzheimer's disease, right? So there are billions of dollars being spent on Alzheimer's because Alzheimer's is characterized, at least in part, by deposition of abnormal proteins within the brain, and whether that's causing the brain dysfunction or whether it's just a consequence of something else is difficult to discern. We're going to talk about transthyretin in the most part, and that is the most common form of amyloidosis that I see and that I guarantee you have amongst your patients, people with this disease. You just don't know it because you haven't looked for it because we didn't have good tests. So amyloid on the right, transthyretin, is by far the most. There is another somewhat common cause that's called, in this parlance, light chain amyloidosis. That is a form essentially of leukemia-like condition. It's closely related to multiple myeloma. And it's because a clone of plasma cells or white cells are excreting immunoglobulins at excess amounts. And these immunoglobulins can precipitate, clog up the heart and other things. That disease is an oncologic disease. And so when we diagnose light chain amyloidosis, they immediately go to the hematology oncology people, because if you don't do that, they all die, and they die quickly. If they get appropriate chemotherapy and the plasma cells are knocked out and no longer producing this abnormal immunoglobulin, then the heart can get better and the people don't die, and you can have absolute complete reversal. So these people get chemotherapy, sometimes stem cell transplants, bone marrow transplants, but the fundamental theory, the fundamental treatment now is chemotherapy, basically. Different is the right, and this is the one we're going to focus on because this is by far the most common form of amyloidosis that exists in your population, as in mine, and this is called transthyretin. In the literature, you'll see TTR, which stands for transthyretin, okay? Transthyretin is a normal protein, and let's go into what exactly that is. Everybody here has heard of transthyretin, but under a different name. So if you worked in a hospital and a nutritionist comes by and says, I want to find out whether Mrs. Smith is adequately intaking calories, he or she will order, or you can order, a prealbumin. Okay? Prealbumin is transthyretin. Prealbumin is a protein that has nothing to do with albumin. The reason it's named prealbumin is because the chemists years ago would put blood onto a column, and a protein that was coming off before albumin came off, they called prealbumin because it comes off before albumin. It has nothing to do with albumin. It's a complete misnomer, and it has completely confused people, and it really should be named transthyretin because that is actually the protein that we're talking about. Because that protein has a short half-life, albumin lasts a long time, transthyretin does not. And hence, if you're thinking somebody's in a starvation state, you can get a blood test to measure how much of this pre-albumin is the test you order, but it really should be called transthyretin. And that protein level will tell you if the liver thinks there aren't enough calories and they're not making enough. Okay, so that's a nutritional issue. The normal function of this protein is to transport other things around the bloodstream. And the two are listed here that are most important. Okay? Thyroxine. So when you have thyroid hormone circulating, it latches onto this transport truck called transthyretin. In fact, the name means transporting thyroid and one other thing, retinol binding protein, which is vitamin A, basically. So that's what this purpose of this protein is. Everybody has it. It's a normal protein. It's made in the liver, circulates in the bloodstream to do its job of transporting thyroid and this vitamin A kind of substance. Now, on the left is what hopefully your transthyretin looks like. So the liver makes one of these, and then four of them get together, and they fit like Lego blocks. They link together to form this tetramer, and that's the transport truck for the thyroid, et cetera. But for reasons that sometimes aren't clear, these four proteins can disassemble, and going from left to right, when they disassemble, much like taking a piece of paper, if you're into origami, you can take a piece of paper and fold it to look like a crane, or you can fold it a different way and it looks like a hippopotamus or something, I don't know. It turns out that in some people, sometimes for genetic reasons we'll discuss, but sometimes for reasons that aren't clear at all, these proteins disassemble and refold and misfold and no longer have the typical structure of transthyretin. And when they do that, then they conglomerate and form what's called amyloid fibrils. Very similar to what goes on in Alzheimer's, but in this case, it's mostly the heart, the nerves, the gut, and some other tissues. So going left to right, the liver makes the transthyretin and the TTR there. Usually it's a tetramer with these four proteins linked together, but they can disassemble, misfold, form these fibrils, and then muck up the function of vital organs like the heart and the nerves. When you get to the far right, now you have this clinical condition of amyloidosis. The organs aren't working because these proteins, just like pouring concrete into something, these proteins muck up the normal function. In the heart, it's actually in the cells, in the nerves, it's in the axon, and it prevents normal function of these organs. Now, one of the reasons for this is that you're unlucky and you're born with a mutation. Transthyretin has 127 amino acids. There are at least 130 known mutations that cause this disease, because if you have a mutation, the normal folding may be messed up, and therefore you may have a predilection for unfolding the proteins and misfolding the proteins. And left to right, they're different. The top there are different mutations, whether you have a valine or not, et cetera. And it's very interesting to look at these because some of the mutations lead mostly to neurologic symptoms on the left. Some on the right mostly lead to heart symptoms, and we do not know why that's the case. There are differences if you happen to be from Portugal, for example. So in certain parts of the US where there's a high Portuguese immigrant population, like Fall River, Massachusetts, they have a lot of people on the left side because the Portuguese have a particular mutation, the V50M mutation, in which they have the neurologic mutation. Scandinavians have the same mutation, but it appears 20 years later, and we have no idea why. In fact, once you get into this field, you find out the statement, "we have no idea why," is everything we talk about, "we have no idea why," is like common here. It's unbelievable. Now, I'm going to skip that one here. What that leads to is impairment. So if you have people who actually have the disease of amyloid, and then you do simple questionnaires, you heard about questionnaires about depression and things a moment ago. If you just do simple questionnaires like, how are you feeling? How's your life quality? Can you do normal things? Can you walk? Can you move your bowels normally? In this case, the vertical axis, the higher you are, the better your quality of life. So if you look at people that have one of these mutations, hereditary transthyretin amyloidosis, their quality of life is worse on these questionnaires than multiple sclerosis, diabetic nephropathy, patients with heart failure, patients with Crohn's disease or irritable bowel syndrome. This is a real problem because these people have multiple systems that aren't working due to these abnormal depositions. It's a real issue. And those symptoms and signs are enunciated here. Now, obviously, as a cardiologist, I mainly see the cardiovascular manifestations, which usually means heart failure, but not always. It can be arrhythmias. So if you look at where you can find enriched populations of amyloid, it's atrial fibrillation patients, for example. It's aortic stenosis patients. So it turns out that patients who are referred for TAVR, right, transcatheter aortic valve replacement, 10% of them have amyloid, and just nobody looked for it. If you look at hypertrophic cardiomyopathy patients where people have thick hearts, 10% of them have amyloid. It's just that nobody looked for it, right? They ascribed it. In fact, we've had 2 people in the last 2 weeks in our hypertroph clinic who we tested, and lo and behold, what they had was hereditary amyloidosis. They didn't even have hypertrophic cardiomyopathy. It's just that nobody had done the right tests that we're going to talk about in a minute. But there are other conditions, and the problem is that when your nerve system isn't working, the symptoms are so nonspecific. So for example, look at autonomic conditions here. Orthostatic hypotension, urinary incontinence, and erectile dysfunction. That's my entire patient population right there, right? Because my patients are 82 years old. They all have either hypotension, urinary incontinence, erectile. So that's the problem, is that these aren't specific. And that's why it didn't click in people's minds that, gee, maybe this person has amyloidosis, right? So there are certain things that you need to look for amongst these that will trigger, and in our Heart Institute now, if there's certain things that are there, 100% of the time, those people will have an amyloidosis workup. And what we've found is that with these things that I'm about to tell you, your yield will be 10 to 20% of the people who meet the following criteria will have amyloid in your patient practice. It's millions of people in the United States. What are those? Heart failure. Well, obviously, if somebody comes to me having had a big MI and their ejection fraction is 20%, I don't necessarily need to look for a cause for their heart failure. But if they have unexplained heart failure, if they have atrial dilation, I run the echo lab. People will say, look at this echo, both atria are significantly dilated. Why is that the case? Well, your receiving chambers of the heart are going to be stretched out if blood can't get into the ventricles. And so biatrial dilation in particular, or unexplained left atrial dilation, is an important marker for there may be amyloid there. If they have aortic valve sclerosis or stenosis, I already mentioned the yield there is 10 to 20%. That's huge. If they have increased cardiac mass, I'm going to show you something in a minute about that. If they have spinal stenosis or carpal tunnel syndrome. Now, you may not think there's a connection between carpal tunnel syndrome and heart. There is. In our practice, when we look down the problem list, if somebody has heart failure and carpal tunnel syndrome, bingo, they go get an amyloid test. And 10% of those people have amyloidosis as the cause of their carpal tunnel and of their heart failure. And that's true of spinal stenosis that isn't explained. If somebody had trauma to their lumbar spine and has spinal stenosis, okay. But if they have unexplained spinal stenosis, a significant percentage of those people actually have amyloid deposits that have caused their spinal stenosis. And lastly, peripheral neuropathy, which is usually blamed either on diabetes or, quote, idiopathic peripheral neuropathy, right? My feet are numb, and you go, yeah, okay, your feet are numb. Next, you don't sort of think about it. But if somebody comes in and says, I'm short of breath and my feet are numb and I had carpal tunnel syndrome, you go, bingo. The EKG historically has been used. It's not very good, but I'll tell you that a totally normal EKG makes cardiac amyloid much less likely. 95% of all people with cardiac amyloid have some abnormality on the EKG. The problem is the abnormalities are not specific. So here is an amyloid EKG, and what you'll read in books is low voltage, right? That's a signal, and it is true. somewhere between 30 and 60%, depending on the form of amyloid, will have low voltage. That's listed here. If you look at the limb leads, you go, gee, where's the QRS? I've had patients where their P waves are bigger than their QRS. You go, well, that's not normal. They have pseudo-infarct patterns. So you'll see EKGs that says, gee, Mrs. Jones, when did you have your heart attack? Well, I never had a heart attack, right? Because the EKG will be read by the computer as saying inferior MI or old anterior MI. That's another finding. Atrial arrhythmias, because they're common in this condition. The biggest thing, though, is if you see low voltage, it could be just a fat person or something, but if you see low voltage like that, and the echo looks like this, and you go, holy mackerel, this person should have huge QRSs because look at all that heart mass, and they have little dinky QRSs. That should be a moment where a light goes off in your head. However, what has totally changed this field, and the test that we do on 100% of these people that have the carpal tunnel and the heart failure, et cetera, is this test, a bone scan. A bone scan. We've been doing bone scans for 40 years, and what we didn't realize, and the first case I saw of this was in 1977, and nobody thought that if you have a bone scan and your heart lights up. So on the left is a bone scan of a normal person, on the right is a person with amyloidosis. What's the difference? The heart lights up in the amyloid patient. So somehow the technetium pyrophosphate bone scan hones in for transthyretin, not for the immunoglobulins, but for transthyretin amyloidosis. Over 90% of the people will have a bone scan that lights up. This has completely changed the field because it means you don't have to do a heart biopsy. If somebody has the typical findings of amyloid and has this scan, 95% of them have amyloid. We stop there. We don't even get tissue to look for birefringence and all that stuff we used to look for. We just say, you have amyloid, and now we're going to treat you. Okay? Now, one of the reasons we didn't used to care about that is because we had no treatment. And if you don't have a treatment, sometimes you go, well, I don't care if you have amyloid because we have no treatment. Now we have treatments. We'll talk about it. Another test that you will see in the literature is speckle tracking strain rate imaging. Now, to an audience of echo experts, that's meaningful, but I'm just going to give you a 1-minute lesson on what is echo lab strain rate imaging. So on the left is that red is normal. Red means normal movement of the heart. The echo computers are so good now, they take every little speckle within the heart and they see whether it moves. It's not the global, it's every little speckle within the heart, and they track it real time. This is looking at the heart down the barrel of the heart. The center of that target is the tip of the heart. Okay, so that's what a normal person looks like. Here's what somebody who, blue means no movement of the heart. This is an old anterior MI because we're looking down the barrel of the heart. The front of the heart is up. This person has no movement of the front of their heart. They have good movement of the inferior wall. That's a typical anterior MI. Here's a typical inferior MI. The bottom of the heart's not moving. The rest of the heart's moving. This sounds pretty good. Here is Takotsubo cardiomyopathy, right? Broken heart syndrome, right? Somebody who, the first case I saw of this was, true story, a woman is sitting in her kitchen making dinner and there's a knock on the door. She opens the door and a bear is standing there in front of her. The bear had knocked on her door. This was in the mountains around LA. She clutched her chest, saying, oh my God, and she had an elevated troponin and an abnormal EKG. Looks like a heart attack, but what it was the stress cardiomyopathy, which is release of catecholamines. The unique thing about that is most of those people, it's the tip of the heart. That's what that shows us. The red around is the base of the heart, all moving fine. The tip of the heart's not moving fine. But look at this patient. This patient, the tip of the heart is red, moving terrifically, but the entire base of the heart is not moving. That's amyloid. And if one sees that, it's so specific for amyloid that there are now people, I don't happen to be one of them, but they're amyloid experts who say, this should be the test we do, because if you do speckle tracking and you see this, then bingo, the person has amyloid. It's not quite that easy because bundle, branch block, and other things can mess this up. But it's true, if you see that, that is amyloid too. So we will accept either the bone scan being abnormal with the heart lighting up or this particular echo as being confirmatory evidence for amyloidosis. Now, as I mentioned a moment ago, if we didn't have treatments, this all might be moot, but now we do. So where might we be able to treat this particular thing? Well, first of all, I said that protein is made in the liver. Double-click it. Yeah, I don't see that. That's the top one, right? Yeah. Okay, I'll walk you through this. So The protein is made in the liver. So one way we could do this is rip out the liver and put a new liver in. And in fact, that was the treatment. And obviously liver transplant, if you had hereditary transthyretin amyloidosis, the treatment up until last year was liver transplant. And it's still used. That's a pretty big treatment, you know. Now we don't have to do that. What can we do? We give an interfering substance that prevents the liver from making this protein. And I'll show you the evidence that works. So there are several now that do that. There are 2 that are approved by the FDA as of last October. And what they do is they turn off the gene still produces messenger RNA, but the message isn't translated into protein production. And we now have ways to do that, okay? Or maybe from that tetramer where it says TTR tetramer going to the dissociation, maybe we could somehow glue these things together to prevent them from dissociating and then clogging up the system. That's possible if we had stabilization. The next drug coming out in the next 2 months does that, and I'll show you evidence that that works too. Or maybe we could remove amyloid. Wouldn't that be great if somebody had amyloid plaques, send some enzymes in there to chew it up and pull it out and stuff. There are some things that do that. Now, if you look at some of these are old drugs that you've had for a long time. Like, for example, lower left side, doxycycline, right? An antibiotic. Well, as an offshoot of this, it turns out that that can help. And so the standard regimen until the drugs came out in the last few months was to give doxycycline and another drug, diflunisal, listed in the upper middle there. Diflunisal was a non-steroidal, but it turns out it has a unique action that helps stabilize. So those were the treatments, and there are others too. You'll read about these green tea extract, ursodeoxycholic acid, and in fact, that cocktail was what we used in all our patients with transthyretin amyloidosis until the newer drugs came out. And the newer drugs, 2 of them do this. They turn off production of the transthyretin protein. So in gray is the normal transthyretin protein production. In purple, after you've started therapy, you turn off and you lower the amount of transthyretin produced by 80%. And if you do that, then the thinking is, well, gosh, at least you won't have further deposition of amyloid. And in fact, there is proof that that's the case. So in purple is treatment with one of these injectable drugs. In gray is no treatment, randomized in these trials. Left to right is how the patients feel. And what you see is that the patients who are given the drug on their health inventories are stable. And once you prevent new production of proteins, you halt the amyloidosis in its tracks. The gray, randomly given placebo, didn't have that. And then in the midpoint, they're crossed over and they now get the shots. And what you see is they also now have stabilization. But notice an important point, they don't go back up to the purple. So you've had further progression of disease that you've halted, but you haven't regressed it. So now, as soon as we find somebody with transthyretin amyloid, we treat them because we don't want to, it doesn't appear, at least over the short term, that you can regain, you can stabilize. We'd love to regain, and my prediction is we will be able to do that. We just aren't doing it yet. One of the ways you can do it, in this diagram, in the middle where the rectangle is, that's a thyroid hormone. So the thyroid hormone fits in there and is transported by this tetramer protein. That little thing fits in there, and it fits like a glove. Well, it turns out, thyroid hormone's on the left, the substance on the right, tafamidis, in which I'll show you data, mimics fitting into this tetramer like thyroid hormone does, but it does a really good job of preventing the dissociation of these proteins. And so you displace thyroid, and instead you put in this tafamidis molecule, and it fits right in there like a glove, and it binds the four to prevent their dissociation. So this is the beginnings of molecular medicine and cardiology. And if you look at people who, this is the normal survival of amyloid. The green people are further along. I'm sorry, these are just different stages, stage 1, stage 2, or stage 3 survival, but cardiac amyloid is not a good thing to have. But here's what happens if you look at the tafamidis. This is a New England Journal of Medicine article from 5 months ago. And this is just looking at death. Right? So after a period of time, the curves diverge, and this is the first study that has ever shown that you can prevent death in amyloid patients with a medicine. And the curves diverge after this, and they continue to diverge, and it's quite stunning. This is at the FDA right now. We expect it'll be out in about 60 days. Can you make patients feel better? Yes. This is how far they can walk in 6 minutes. Red is no tafamidis, blue is tafamidis. In this particular study, the patients still got a little worse. That's disconcerting, but they didn't get as worse as quickly as the people who didn't get therapy, and that's true of quality of life also. So amyloid is bad, but finally there are effective therapies. There are now 2 and 1 to come in the next 60 days, which will halt this, and we don't yet know whether we combine therapies, we continue. We don't know that because we're in the infancy of treating amyloid. But at least if somebody has amyloid, we now have good therapies. Now, a couple of things about treating more conventional heart failure. Patients complain of volume overload. We talked about that a little bit when we mentioned salt. So most of the time you're going to give diuretics to assist the patient's kidneys in eliminating. And if you look at the kidney response to the diuretics, furosemide is the most commonly used diuretic. It is not the best of the so-called loop diuretics. If the vertical axis is how strong the diuretic is in terms of overall production of urine and salt, of salt and water in the urine, and torsemide, the middle one there, is much better than furosemide in that regard. So why do people use furosemide? Well, part of it is because they're used to it, and the other part is it's dirt cheap. If you look at oral furosemide, these are the actual acquisition costs for our 50 hospital system. It costs the hospital 4 cents to buy furosemide. So that's why it's used. But if you're in trouble and the patient isn't responding, why do they all respond to intravenous Lasix when you put them in the ER, but they don't respond to oral Lasix? It's absorption, malabsorption, and if you want to get absorption, you use torsemide. And that simple switch often avoids a hospital stay. So if somebody is volume overloaded and not responding to their oral furosemide, you can give it intravenously or you can switch it to oral torsemide. And most of the time, we give IV Lasix all the time in our office, but typically what we do is just switch the diuretics, or we'll add diuretics to their regimen to achieve diuresis. What about the Reen and Angiotensin modulators? Everybody in this room has patients on ACE inhibitors and angiotensin receptor blockers. That's because if you look at this is death in the vertical axis, and there is a reduction when patients are given, in this case, ACE inhibitors. ARBs are the same. ACEs and ARBs for heart failure are about roughly the same. They lower mortality by about 20%, okay? And more may be better. But because of the study from a few years ago, we no longer in our clinic give ACEs or ARBs for heart failure because they have been superseded by a better drug. The brand name is Entresto. It's listed as sacubitril valsartan on the formula because it's actually 2 medicines in 1 pill. And here it's called LCZ696 because they didn't have a name for it. But if you look at mortality, morbidity, hospitalizations, rehospitalizations, quality of life, exercise, in every single parameter, this drug beats an ACE inhibitor. And hence, ACE inhibitors were terrific 20 years ago, but they have been superseded by more modern twice-a-day sacubitril valsartan. Spironolactone, a drug that was developed over 50 years ago for hypertension, now used for acne and a bunch of other stuff, but it turns out that it's really useful in heart failure, right? Reduces mortality by 30%. So, if you look, and I'll show you the data here in a second of how we're doing as a nation, one thing that would really make a difference is for us to use more spironolactone in systolic heart failure patients. Although it is a diuretic, that's not the main reason we use it. It prevents scarring of the heart, prolongs life, makes patients feel better, and of course the downside is it increases potassium levels. So that's important to remember if you're going to use spironolactone. Now lastly, heart rate. It's very important to reduce heart rate in heart failure. Why is that the case? This is not true, by the way, for amyloid hearts that don't have any volume. They actually may need a faster heart rate. But for a failing heart due to systolic heart failure, here's the experiment that proves what the issue is. So in red is your heart. If I took your heart out and put it in a petri dish and then measured how it contracted, the faster your heart goes, the stronger it gets, up to about 150. And after that, it starts getting weaker, which is why if somebody's in sustained tachycardia at 180 beats per minute, they can develop heart failure because the heart involutes a little bit in terms of molecular mechanisms and tries to protect itself. And green is the patient with systolic heart failure. The heart has already genetically reprogrammed itself. It doesn't like faster heart rates. So even in the normal range, as the heart goes from 50 to 60 to 70 to 80, a heart failure patient's heart gets weaker, not stronger. And once this was recognized, it explained the paradox of why is it that beta blockers are good for heart failure patients, even though beta blockers in a normal person lowers their ejection fraction. It's because heart failure patients are not normal people. They don't have normal hearts. The hearts respond differently. And that was shown here. Look on the right, okay? This is after metoprolol randomly assigned. This is the ejection fraction, which started at 24 or 25% and went up. If you want to improve somebody's ejection fraction medicinally, the strongest medicines to do that are the beta blockers, like metoprolol, okay, on this. There are three proven, bisoprolol, metoprolol, sustained release, and carvedilol. And here are, no matter what group you have, yeah, I feel a little bit bad, or I'm really bad, or I'm young, or I'm old, or I'm male or female. If you have a low ejection fraction defined as 40%, you will do better on a beta blocker. So, you have to use a beta blocker in this. It's the single most important treatment for patients with reduced ejection heart failure. And then in the last few years, we've had a second agent which opened our eyes to what you can do even in so-called normal heart rates. So here's a study. Red is placebo, blue, and both groups, by the way, are on beta blockers. Blue is placebo plus this drug called ivabradine, which is Corlinor is the trade name. Here's the most stunning elucidation of this multi-thousand patient study, though. The heart rate is an important predictor of how somebody's going to do, even in the range that you and I wouldn't bat an eye at. So look at this. If your heart rate's 75 in green, or 72 in red, or 68 in yellow, or 62 in orange, or 60 in purple, the difference in death and in heart failure hospital stay is enormous. And yet I would argue that if somebody came into your office and had a heart rate of 72, you wouldn't think twice about it. You should, if they have heart failure. Going from 72 to 60 is as important as putting one of these new medicines into the system. So lower the heart rate to 60, that's the goal. And in this study, the EKG heart rate was the defined heart rate. Problem with heart rates is you walk somebody into a room and the MA takes their heart rate and maybe they just walk 27 yards or something. When they have an EKG, they have to lie down, the leads are put on, and so the heart rate comes down a little bit. That's the heart rate we base these numbers on. Many other proven remedies that we don't have time to go into, and this is the realm really of the heart failure experts. So in 2019, what's the current paradigm? For symptom relief, you control volume with diuretics, usually loop diuretics, right? Furosemide. We prefer torsemide because it works better. And then you use drugs to slow the progression of the disease. In the Reen and Angiotensin, it used to be ACE inhibitors and ARBs. Now it's the sacubitril/valsartan combination. You use a beta blocker, and if you can't get the heart rate down to 60, you add a second agent, which is ivabradine. It's misspelled there, and then spironolactone. Using that triad, okay, you add many years of life to your patients. You prevent hospitalizations hugely, and you reduce the death rate from about 11% per year to about 3.5% per year. I mean, there aren't too many things that you and I do that lower death by 70%. Just this simple triad is all you need to do, right? And yet, if you look at how well are we doing, we're doing a lousy job. And the vertical axis here is an index, and left to right are all the VA hospitals in the United States. And the good performers versus the bad performers, there's a 100% difference in VA hospitals using the same formulary between how their patients are doing and how they're applying it. If you look at cardiology offices, it's the same thing. This is not advancing. Can you advance, please? So here is quality of life, okay? If you look on the left, there are some cardiology practices where the quality of life is 0 in their heart failure patients. There are other where it's 80% good quality of life. Would you rather see the cardiologist at 0 or at 80, you know? It's like, you gotta be kidding. Next slide, please. And these are people who were sick enough to warrant having a defibrillator put in. Now, the stunning thing about these are Medicare data, 19,000 Medicare patients, okay? In red is the use of any of the therapies, A beta blocker, an ACE inhibitor, NARB, Entresto, spironolactone. In red are what people were on any of those at any dose. And look at the data. A quarter to 30 to 40 to 50% of people are on none of those therapies. And yet they're sick enough with an EF of less than 35 to warrant a defibrillator. That's criminal, honestly. Okay? So what can we do about that? Treating heart failure is not rocket science. That's what I would say. It's actually much harder, but because we're dealing with people, not just physics, right? So it is true. But with appropriate medications, close follow-up, and attention to detail, your patients will live longer and live better, and I thank you for your attention.